Good morning everyone. Today we are going to continue in our book club presentation on the fundamentals of diagnostic imaging. Today we continue with our colleague Dr. Abdulwahab on the chapter of pulmonary infections. You may start.
Good morning, dear colleagues. Today we will start with pulmonary infection, hoping that we will all get benefit from it. So, starting with mechanisms of disease and radiographic patterns. Microorganisms responsible for producing pneumonia enter the lung and causes infection by three potential routes, either via the tracheobronchial tree or pulmonary vasculature, or direct spread from infection in the mediastinum, chest wall, or upper abdomen. Before passing in the details of pulmonary infection, I would like to make a quick review for the normal anatomy of the tracheobronchial tree. It will start from the trachea to the main bronchus, then the lobar bronchus, then to the segmental bronchi, and then interlobular bronchus. Then I have made a shortcut. Think about TRAM, terminal bronchi, respiratory bronchus, then you have the alveolar canal and the alveoli. Talking about infection. Infection via the tracheobronchial tree is generally secondary to inhalation or aspiration of infectious microorganisms and can be divided into three subtypes, which is lobar pneumonia, lobular or bronchopneumonia, and interstitial pneumonia. Lobar pneumonia is typical of pneumococcal pulmonary infection. In this pattern of disease, the inflammatory exudate begins within the distal airspace. The inflammatory process spreads via the pore of Horn and canals of Lambert to produce non-segmental consolidation. If untreated, the inflammation may eventually involve an entire lobe. Because the airways are usually spared, air bronchograms are common and significant volume loss is unusual. So, in lobar pneumonia, we have consolidation and air bronchogram. Passing to the lobular or bronchopneumonia is the most common pattern of disease and is most typical of Staphylococcus pneumonia. In the early stages of bronchopneumonia, the inflammation is centered primarily in and around the lobular bronchi, which is the fourth step in the tracheobronchial tree. And as the inflammation progresses, exudative fluids extend peripherally along the bronchus to involve the entire pulmonary lobule. Radiographically, multifocal opacities that are roughly lobular in configuration produce a patchwork quill appearance because of the interspersion of normal and diseased lobules. Bronchopneumonia is the most common cause of multifocal patchy airspace opacities. Exudates within the bronchi accounts for the absence of air bronchogram in bronchopneumonia. With coalescence of affected area, the pattern may resemble lobar pneumonia. So in lobular pneumonia, we have patches and no air bronchogram. In atypical pneumonia, as in viral and mycoplasma infection, there is inflammatory thickening of bronchial and bronchular walls and the pulmonary interstitium. This results in a radiographic pattern of reticulonodular opacities. Air bronchograms are absent because the alveolar spaces remain aerated. Segmental and subsegmental atelectasis from small airways obstruction is common. This was the talk about the tracheobronchial tree. Passing to the pulmonary vasculature spread of infection, the pattern of parenchymal involvement is patchy and bilateral because it is through the pulmonary vasculature. Talking about the direct spread usually results in a localized parenchymal process adjacent to extrapulmonary source of infection. If an organism causes extensive parenchymal necrosis, an abscess may form. Till now, we were talking about the mechanisms of infection. We knew it is through three typical ways: tracheobronchial, vasculature, and direct spread. The tracheobronchial is divided into 4 subtypes. Now passing to the bacterial pneumonia, we have gram-positive bacteria. Staphylococcus pneumonia is a gram-positive organism. Streptococcus pneumonia is a gram-positive organism. Patients with sickle cell diseases or those who have undergone splenectomy are at partial risk for severe pneumococcal pneumonia. Pneumococcal pneumonia tends to begin in the lower lobes or the posterior segment of the upper lobes. The typical radiographic appearance of acute pneumococcal pneumonia is lobar consolidation. Air bronchograms are usually evident, and parapneumonic effusion or empyema may be seen in 50% of patients. With appropriate therapy, complete clearing may be seen in 10 to 14 days. In older patients or those with underlying disease, complete resolution may take 8 to 10 weeks. Patchy lobular opacities and reticulonodular patterns may be seen. In children, pneumococcal pneumonia may present as a spherical opacity called round pneumonia, simulating a parenchymal mass. Staphylococcus aureus pneumonia typically produce bronchopneumonia, which we said it is the most common type of pneumonia. Radiographically appears as patchy opacities. In severe cases, the opacities may become confluent to produce lobar opacification. Air bronchograms are rarely seen. In adults, the process is often bilateral and may be complicated by abscess formation in 25 to 75%. So abscess formation is common. In patients who develop pulmonary infection from hematogenous seeding, multiple bilateral poorly defined nodular opacities can be seen with cavitation. Parapneumonic effusion and empyema are common. Nematocele formation is common in children and may lead to pneumothorax. Nematoceles may be distinguished from abscess by their thin walls, rapid change in size, and tendency to develop during the late phase of infection. Streptococcus pyogenes is similar to staph. There will be lobular or segmental lower lobe opacities. The process may be complicated by abscess formation, which was present also in staph, and cavitation. Empyema is relatively common. Talking on Bacillus anthrax, the primary radiographic manifestation of intrathoracic anthrax are related to the underlying pathology of hemorrhagic lymphadenitis, mediastinitis, and hemorrhagic pleural effusion. So we expect mediastinal widening, hilar enlargement, and often pleural effusion. Talking about the CT, demonstrates pleural effusion, lymphadenopathy, and CT scan may show extensive adenopathy in the setting of normal radiographs and should be obtained if the suspicion of anthrax is high. Gram-positive is over. We have gram-negative bacteria. Gram-negative bacteria are increasingly important causes of pneumonia in hospitalized patients, accounting for more than 50% of nosocomial pulmonary infection. Radiographic appearance of gram-negative bacterial pneumonia varies from small, ill-defined nodules to patchy area of opacification. Involvement is usually bilateral, multifocal, and the lower lobes are most frequently affected. In my mind, I said everything negative is down, so they will always most commonly involve the lower lobes. Abscess formation or cavitation are relatively common. Parapneumonic effusion is common and often complicated by empyema formation. This is in general. Talking about the Klebsiella, Klebsiella can be distinguished from pneumococcal pneumonia by 3 radiologic appearances, which is bulging interlobar fissure, abscess formation, which is not common in pneumococcal pneumonia, and pleural effusion and empyema is higher. Pulmonary gangrene may be seen but is uncommon. Passing to H. influenza. H. influenza infection is most common among patients with COPD, alcoholism, and diabetes mellitus, as well as those with an anatomic or functional splenectomy. It most often causes bronchitis, although it may extend to produce bilateral lower lobe bronchopneumonia.
What's the difference between anatomical and functional splenectomy?
Functional splenectomy.
Anatomical or functional splenectomy?
Anatomical
What's the difference?
is complete يعني extraction.
Removal of the surgical removal.
Surgical
What
removal.
about functional splenectomy?
And spleen is not
Spleen is not
non-functional.
For example, sickle.
Sickle.
Okay?
Yeah.
Functional splenectomy. It's not removed surgically, but it's not working.
Yeah. In Pierre-Reginosa, the radiographic pattern of parenchymal involvement depends upon the method by which the organism reaches the lung.
What's PRH?
Pseudomonas. So, and we have, if the infection is via a lung, infection reaches the lung via the tracheobronchial tree, then we expect patchy opacities with abscess formation. But diffuse bilateral, ill-defined nodular opacities usually reflect hematogenous dissemination. Every hematogenous dissemination you should suspect diffuse and bilateral. Now passing to anaerobic bacterial infections. The majority of anaerobic lung infections arise from aspiration of infected oropharyngeal contents. All anaerobic pulmonary infection produces a similar radiographic appearance. The typical radiographic appearance is peripheral lobular and segmental airspace opacities, patches. Cavitation within the areas of consolidation is relatively common, and discrete lung abscess may be seen in up to 50% of patients. Hilar mediastinal lymph node enlargement may be seen in those with lung abscess. Empyema with or without bronchopleural fistula formation is a common complication and is seen in up to 50% of patients. Now we have atypical bacterial infection. Actinomycosis. The radiographic pattern of actinomycosis is often indistinguishable from that of nocardiosis. Finding consists of non-segmental airspace opacities in the periphery of the lower lobes. In some cases, the infection manifests as a localized mass-like opacity that mimics bronchogenic carcinoma. Extension into the pleura will cause empyema. Into the ribs chest wall will cause osteomyelitis of the chest wall and abscess formation. Involvement of the ribs is seen as wavy periosteal reaction or lytic rib destruction. If it becomes chronic, extensive fibrosis may be seen, and rarely the disease is disseminated and miliary pattern.
So actinomycosis and nocardiosis, it has a very distinguishing thing. It does not respect anatomy. It just attacks and weapons of mass destruction.
No.
Lungs and ribs and pleura and chest wall, involved destroy everything in its way.
Aggressive.
It's not localized in the lung or in its side. So it's a very bad infection.
Mycoplasma pneumonia, it is probably the most common atypical pneumonia and accounts for 10 to 30% of all community-acquired pneumonia. In the early stages of infection, interstitial inflammation leads to a fine reticular pattern on the chest radiograph. This may be progressed to patchy segmental airspace opacities, which may coalesce to produce lobar consolidation. CT scan of mycoplasma pneumonia usually appears as patchy airspace opacities with tree-in-bud appearance. The process is often unilateral and tends to involve the lower lobes. Pleural effusion may be seen in consolidative form of disease and occurs most commonly in children. Lymph node enlargement is uncommon but may be seen in children. Radiographic resolution may require 4 to 6 weeks. Talking about mycobacterial infection, Mycobacterium tuberculosis. Two forms are seen clinically and radiographically: primary infection and post-primary reactivation. In the primary infection, there may be normal chest radiograph, or it will appear as any type of pneumonia. But sometimes there is a Rathex lesion, or what is called Rathec's complex or gone lesion, which is calcification within the lymph node. This is typical for primary TB. Sometimes primary TB could be associated with pleural effusion. And the most important is post-primary reactivation. Tends to occur in the apical and posterior segments of the upper lobes and the superior segments of the lower lobes. Because it is well oriented, that's why aerated, and that's why it tends to occur in these locations. Ill-defined, patchy, and nodular opacities are commonly seen. Cavitation is an important radiographic feature of post-primary TB and usually indicates active and transmissible disease. Once receiving treatment, granulomatous response will appear, and parenchymal healing is associated with fibrosis, bronchiectasis, and volume loss in the upper lobes. Miliary TB may complicate either primary or reactivation disease. It results from hematogenous dissemination of tubercle bacilli and produces diffuse bilateral 2 to 3 millimeter pulmonary nodules.
Question.
Yeah.
Primary TB occurs in where in the lung most commonly?
Lower lobes.
Lower lobes.
No.
Post-primary?
No.
Upper lobes or apex.
Yeah, no.
So why is that?
The
If primary
mycobacterium
happens in the lower lobe, the reactivation should be in the lower lobe.
it migrates.
It does not migrate.
يعني
Because of gravity.
Gravity should
لا it's lower
Down,
gravity
not
down there.
upper. Lower, not upper. The primary is in the lower.
No,
Why the reactivation occurs in the upper?
because it requires well aeration. It will go up يعني the mycobacterium.
It needs better aerated
No.
areas. Okay. But how does it go from the lower to the upper?
It goes via hematogenous
Spread.
No. The post-primary is done, spreads from the primary to the apex via hematogenous spread. From the blood goes everywhere, and it will go into areas where more oxygen is available. That includes the bone marrow, the renal papillae, and the lung apices. These are the most common signs of post-primary TB. Now, and of course, we don't see the renal TB or the bone marrow as common as the lung, but the thing is, the primary infection occurs in the lower aspect of the lung. Reactivation or secondary post-primary TB will go by hematogenous spread into the well-aerated areas.
تمام.
Get it?
تمام. Thank you. Post-primary tuberculosis frontal radiograph in a 49-year-old female with a cough and hemoptysis shows bilateral upper lobe reticulonodular opacities with right upper lobe cavity. CT scan through the upper lobes at the lung windows confirms the presence of cavity and bilateral upper lobe tree in bud opacities. This tree in bud opacities that reflect endobronchial spread of disease. Sputum culture were positive for mycobacterium. Passing to atypical mycobacterium. We have Mycobacterium avium intracellulare. While cavitation is common, pleural effusion, lymph node enlargement, and miliary spread are distinctly unusual. Viral pneumonia. Talking about influenza, in adults with influenzaal pneumonia, there is often bilateral, lower lobe, patchy airspace opacification. In children, a diffuse interstitial reticulonodular pattern is more commonly seen. Swine flu infection due to H1N1 influenza or swine flu was first described in 2009 and has produced a spectrum of illness from self-limited disease to fatal pneumonia. Typical radiographic and CT findings in swine flu pneumonia include patchy ground glass or airspace consolidation involving the central and lower lungs, with progression to confluent bilateral airspace consolidation in the most severely affected patients. Respiratory syncytial virus and parainfluenza virus are common cause of epidemic viral pneumonia in children. Findings are similar to other viral pneumonias, means patchy airspace opacities, bronchial wall thickening, and tree in bud opacities. Varicella zoster is a little bit common, and we can see the x-rays in our daily life chest radiograph characteristically show diffuse bilateral ill-defined nodular opacities 5 to 10 millimeter in diameter. In some patients, these opacities involute and calcify to produce innumerable small 2 to 3 millimeter calcified nodules. SARS-associated coronavirus, unilateral or bilateral areas of airspace opacities are seen on initial radiograph in the majority of affected patients. The opacities are typically peripheral and lower zone in location. Occasionally, initial radiographs are negative. CT demonstrate areas of ground glass opacities and or consolidation. Lymphadenopathy, pleural effusion are not characteristics. Are you tired or I'm fast? Okay. Now, fungal pneumonia. In all cases, the fungi elicit a necrotizing granulomatous reaction. Histoplasmosis, a routine chest film, demonstrates multiple, well-defined calcified nodules less than 1 centimeter in size, with or without calcified hilar or mediastinal lymph nodes. May be the only indication of prior infection. We have acute histoplasma infection. It presents with subsegmental airspace opacities with or without nosocomial hilar lymph node enlargement, or the initial chest X-ray could be normal. If the patient inhales a large inoculum, fairly discrete nodular opacities 3 to 4 millimeter in diameter are seen with hilar adenopathy. Alternatively, acute histoplasmosis may result in a solitary, sharp defined nodule less than 3 centimeters in diameter, termed as histoplasmoma. Histoplasmoma are more common in lower lobes and frequently calcify. So we have either nodular opacities or it appears as a single nodule. Bloodborne dissemination, the chest film most commonly shows widespread 2 to 3 millimeter nodules that are indistinguishable from those of miliary TB. In my mind, I said histoplasmoma is all. And with whatever in your mind, it can cause everything. Coccidioidomycosis. There are 4 types of clinical and radiographic coccidioidal pulmonary infection. In acute phase, the chest radiograph may be normal or shows focal or multifocal segmental airspaces that resolves over several months. Hilar mediastinal adenopathy, pleural effusion may be seen in association with parenchymal disease. If the symptoms and radiographic abnormalities persist beyond 6 to 8 weeks, it's called persistent. The radiographic features of persistent pulmonary disease include coccidioidal nodules or masses, coccidioidoma, persistent area of consolidation, and miliary nodules. Coccidioidal nodules are areas of round pneumonia, usually located in the subpleural region of the upper lobes. These nodules tend to cavitate rapidly and produce characteristic thin-walled cavities. Chronic progressive disease. In the third type, upper lobe fibrocavitary diseases similar to post-primary TB and histoplasmosis is seen. And the fourth type is disseminated, is relatively rare and usually affects immune-compromised patients and non-Caucasians. Blastomycosis, the most common manifestation of the disease, is homogeneous non-segmental airspace calcification with a propensity for the upper lobes. Cavitation can occur, and the third pattern is diffuse reticular opacities. Now, Aspergillus. Aspergillus species are responsible for a spectrum of pulmonary disease in humans. These include aspergilloma, semi-invasive aspergillosis, invasive pulmonary aspergillosis, and allergic bronchopulmonary aspergillosis. The invasive is common in immune-compromised patient, and the last one is present in hyperimmune patient. An aspergilloma is seen as a solid, round mass with an upper lobe cavity, with an air crescent separating the mycetoma from the cavity wall. Mycetoma is usually free within the cavity and dependently on decubitus, radiographs, or CT. Progressive apical pleural thickening adjacent to a cavity is a common radiographic finding and should prompt the search for aspergilloma. Passing to the parasitic infection. In general, parasitic diseases of the thorax are manifested by either a direct invasion of the lungs and pleura, or less commonly, a hypersensitivity reaction. Amoebiasis, it's the disease of the GI tract, but the most common method of pleuropulmonary involvement by amoebiasis is by direct intrathoracic extension of infection from a hepatic abscess. This transdiaphragmatic spread of organism explains why it's present in the right pleural space to produce an empyema, or may involve the right lower lobe to produce an amoebic pneumonia or lung abscess. Hydatid disease of the lung. Pulmonary echinococcal cysts characteristically present as well circumscribed spherical soft tissue mass. In distinction to hepatic cysts, lung cysts do not have calcified walls.
So some stages of hepatic hydatid, third, fourth stage, they show all calcification. In the lung, this does not happen.
No.
It stays as a cyst.
And if you, excuse me, this was my examination case when I was in stagiaire, and I never forget that. He told me, بنتي نص العراق بهم هذا الشمس. No calcification, it's only like a sun. The cysts range in size from 1 to 20 centimeters with a predilection for the lower lobes and the right side. While most cysts remain asymptomatic, patients may present when the cysts develop a communication with bronchial tree. If the pericysts rupture, a thin crescent of air will be seen around the periphery of the cyst, producing meniscus or crescent sign. But if the cyst rupture itself,
Pericyst is the fibrous capsule around the cyst.
no, pulmonary tissue.
The cyst will be intact,
No,
but some air will come between the fibrous capsule and the cyst.
هذا
Listen,
crescent
like
sign.
we said. If
But-
the cyst in the endocyst ruptures the same cyst, what will happen?
Air fluid level will develop.
Airflow.
Air fluid develop. And on occasion, the cyst wall may be seen crumbled and floating within an uncollapsed pericyst, producing the pathognomonic sign of camolate or water lily sign. And rarely, a cyst will rupture into the pleural space, producing a large pleural effusion. Paragonimiasis. In 20% of affected patients, the chest radiograph is normal. The most common radiographic finding is multiple cysts with variable wall thickness. These cystic opacities may become confluent and are often associated with focal atelectasis and subsegmental consolidation. Dense linear opacities representing the burrows of the organisms may be identified. Because the flukes penetrate the pleura, effusion are common and may be massive. Schistosomiasis. As the larvae pass through the lung, an allergic response may develop, presenting radiographically as transient airspace opacities, eosinophilic pneumonia that resolves spontaneously. The larva then passes through the pulmonary capillaries into the systemic circulation. The organism induces a granulomatous inflammation and fibrosis, which leads to an obliterative arteriolysis, resulting in pulmonary hypertension and cor pulmonale. So, in radiographically seen in association as diffuse fine reticular pattern is most commonly seen in association with dilatation of the central pulmonary arteries. Small nodular opacities resembling biliary TB may be seen as granulomata forming around the ova. Now we are talking about the complications of pulmonary infection. Parapneumonic effusion, pleural effusion associated with underlying pneumonia is termed parapneumonic effusion, and it's seen in about up to 50% of patients. Chest wall involvement. When a an empyema collection extends to create an infected subcutaneous collection. It is called empyema necessitate. Lung abscess. Abscesses appear as nodules or masses, typically with central necrosis, with or without air fluid levels, and develop in the gravity-dependent portions of the lung. We mean posterior upper lobes, superior segment, and subpleural regions of the lower lobes. Another complication is pulmonary gangrene. Is a rare complication of severe pulmonary infection when a portion of the lung is sloughed. Image finding include a nodule or mass within a cavity with a crescent of air surrounding the sloughed portion of the lung. Now we have mycotic aneurysm. While a lung nodule or mass adjacent to a hilar vessel in a patient with endocarditis or pneumonia should suggest the diagnosis. Contrast CT is a definitive diagnostic procedure as it demonstrates the relationship of mass with the pulmonary arterial vasculature. Then we have bronchiectasis and Stewart-James syndrome. The typical radiologic finding include a hyperlucent lung with normal or small volume, attenuated vasculature, expiratory air trapping, and occasionally proximal bronchiectasis.
I think this is the only state in which you find small lung that's hyperlucent. Usually hyperlucent lung means emphysema, means
تمام.
over-inflated. Except in Stewart-James syndrome.
No.
It's hyperlucent but small.
Okay. Bronchiolithiasis. This condition reflects to the presence of an endobronchial calcified nodule, most often seen as a result of erosion of a calcified peribronchial lymph node resulting from histoplasmosis or TB. Lastly, fibrosing mediastinitis. Radiologically, there is mediastinal widening with calcification visible. A focal mediastinal mass can also be seen. CT typically demonstrates either a localized calcified right paratracheal or subcarinal mass or soft tissue infiltration of the middle mediastinum with compression or obliteration of the structures. Secondary pulmonary parenchymal changes are the result of central airways and vasculature compromise. The last subject is infection in immune-compromised hosts and in AIDS. Nocardia. The most frequent radiographic presentation is homogeneous, non-segmental airspace opacity or a mass. Cavitation is frequent and hilar lymph nodes may be enlarged. The diagnosis of TB in immune-compromised patient is complicated because skin reactivity and sputum analysis are less sensitive in immune-compromised hosts and the yield of bronchoalveolar lavage is decreased in this patient population. In early stages, it resembles the post-primary pattern in normal patients. Later in the course, when the CD count 50 to 200, the radiographic features include lobar consolidation, mediastinal hilar lymphadenopathy, and pleural effusion. Rim-enhancing nodes with central necrosis on CT scan are a characteristic finding and should strongly suggest TB in patients with AIDS. The radiographic findings are typical and are characterized by diffuse reticular or nodular opacities when AIDS accounts for less than 50 cells per millimeter. Mycobacterium avium, the disease primarily affects the GI tract, but disseminated disease can involve the chest. Lymphadenopathy is the major radiographic manifestation. Infection by Canasi may produce a pattern identical to that of post-primary TB. Viral pneumonia is uncommon in AIDS and other immune-compromised patients with defect in cell-mediated immunity.
So it's very something to keep in mind. Patients with AIDS, which is a viral infection, they usually does not have viral
Pneumonia.
They have bacteria because the defect is just cell-mediated, not humoral immunity.
Tamam. Cytomegalovirus. It is an uncommon cause of pneumonia in AIDS population. Chest radiographs show diffuse bilateral, reticular, or nodular opacities in the lower lobes. Aspergillosis, we have enlightened that invasive aspergillosis usually occur in immune-compromised patients, and most common patients with leukemia and those receiving chemotherapy or on corticosteroids. The radiographic manifestation ranges from large nodule opacity to diffuse parenchymal consolidation. CT, particularly high-resolution CT, is useful for early diagnosis of invasive aspergillosis. The demonstration of a zone of relative decreased attenuation surrounding a dense mass-like opacity has been termed CT halo sign and is relatively specific for invasive aspergillosis in a neutropenic patient.
So this can be life-saving if you demonstrate, if you diagnose the CT halo sign.
No.
Because invasive aspergillosis is fatal if untreated.
Coccidomycosis, pulmonary involvement is usually diffuse and produces miliary nodule, diffuse nodule, or reticulonodular opacities. Hilar and mediastinal lymphadenopathy and pleural effusions are uncommon. So, cryptococcosis, there are several chest radiograph patterns of the disease: single or multiple nodules, single or multiple patchy airspace opacifications, and multiple small nodules mimicking TB. So when it is single or multiple nodules, it mimics bronchogenic carcinoma. Cavitation, lymphadenopathy, pleural effusion are more commonly seen in patients with AIDS than in normal hosts. Candidiasis, chest radiographs in patients with candida pneumonia show diffuse bilateral non-segmental airspace or interstitial opacities. Miliary nodules may be seen, but cavitation, adenopathy, and pleural effusion are not common. Mucormycosis, chest radiographic appearance include a solitary nodule or mass or focal airspace opacity which may cavitate. Pleural effusion is uncommon. Pneumocystis jirovecii pneumonia. The chest radiograph may be normal in the early phase of the disease. As the disease progresses, a fine reticular or ground glass pattern develops.
PCB. Should be PJP.
Pneumocystis carinii.
Previously, it was known as pneumocystis carinii. The new name, ما عجبها اسم ما دام تغيرته. سوت جيروبيسي. كان كاريني
والله دكتور أنا هم قارب النيموسيس كاريني أبد ما قرأت هذا الجيل.
هذا جديد. اسمه جديد. والله جديد.
بس هسه انتبهوا. So, as the disease progresses, a fine reticular or ground glass pattern develops. Progressive disease leads to confluent symmetrical airspace opacification. Pleural effusion lymph node enlargement is distinctly uncommon and should suggest an alternative or additional diagnosis. The diagnosis
so PCP, you don't see pleural effusion, you don't see lymph nodes.
بالضبط.
It's just lungs.
Now, a diagnosis is made by methanamine silver staining of induced sputum samples or bronchoalveolar lavage fluid specimen. Pneumocystis carinii may manifest as single multiple pulmonary nodules simulating fungal infection or such malignancies as Kaposi's sarcoma. Thin-walled cysts or pneumatoceles increase the incidence of spontaneous pneumothorax, complicating it. Systemic pneumocystis carinii infection involves liver, spleen, kidney, and lymph nodes and appear on CT and ultrasound as microabscesses or punctate calcification.
Keep in mind that PCP is an AIDS-defining diagnosis. يعني if you said this patient has PCP,
يعني
has
عنده
AIDS,
AIDS.
definitely.
No.
Okay.
Toxoplasmosis. The disease can be recognized in 4 clinicopathologic forms: congenital, ocular, lymphatic, and generalized. As a radiograph, pulmonary involvement is usually seen in the generalized form of the disease, which affects immune-compromised hosts. Radiographic findings in pulmonary toxoplasmosis include diffuse reticular opacities that resemble those of acute viral pneumonia. Less commonly, airspace opacities with air bronchograms may be seen. Hilar mediastinal lymph node enlargement is common, whereas pleural effusion is rare. With generalized disease, most often seen in patients with AIDS, diffuse bilateral small nodular opacities may be seen. Bone marrow transplant complications can be infectious or non-infectious and are detailed according to time of presentation. And thank you, and I'm sorry if I had any.
Very nice, summarized, up to point, and that's what we need to be focused on more.